Hi, this is Brian Kim. I want to share with you this case of a patient who was referred for a dislocated IOL. And I'm going to share with you how I dealt with this challenging situation. So first of all, this patient has a deep set eye. And then after I did the retrobulbar block, this eye tended to turn down and towards the nose, which is really quite challenging when it comes to being able to get good access for the surgery. And then on top of that, there's significant conjunctival ballooning. So not the most ideal situation, but you're going to see how I struggled through and managed to get done with this case. So this is a patient. I used a standard Lieberman speculum, and I realized it's just way too small. And this is the small blade, narrow blade speculum, and you can see much better access, but again, still deep set and limited access. You can see the eye is turned down into the nose. This is the left eye. I'm drying the surface of the conjunctiva with the Wexel sponge. But you can see I'm turning the eye because the eye is turned down and towards the nose. This is a fixed caliper. I'm marking 2.5 millimeters. I'm indenting with the caliper 2.5 millimeters posterior to the limbus and then 2 millimeters adjacent. And that is the fixed caliper from Epsilon. I have no financial interests. And then this is a 27 gauge inked cannula, and I go ahead and ink those scleral indentations. I use that same cannula to measure and mark the limbus 180 degrees apart, and then using the fixed caliper to indent 2.5 millimeters posterior to that mark and then 2 millimeters adjacent. These are my incisions to help me explant this lens. And using the cotton tip, I have better control with the cotton tip. I make my incision for the 22 gauge thin-walled AC maintainer. But I notice the eye is turned away from me so much that I use forceps to turn the eye up and out, and then I make my incision, which is the contralateral limbal incision to externalize the leading haptic. That's intracameral BSS to fill the chamber because I forgot to place my trocar. So I indent 4 millimeters posterior to the limbus with the back of the trocar. I tunnel through the conjunctiva and sclera. I tunnel about 3 millimeters and I dive down. I know that that's going to be a self-sealing sclerotomy because the trocar cannula is sitting sideways. I go ahead and push some dispersive viscoelastic to fill the anterior chamber and coat the corneal endothelium. And this is the 3 millimeter blade, again, perpendicular to those marks and opposite to that contralateral limbal incision. And that is the triplanar corneal incision. This is 2 microforceps, carefully grasping the trailing haptic, lifting it up into the anterior chamber. And quickly I realize this is a silicone lens because when I try to grab it with the smooth forceps, it just slips out of the grasp. So I grasp it with the serrated toothed IOL holders on my left hand and then sweep the leading haptic up into the anterior chamber. Once I have both haptics in the anterior chamber, I switch the smooth forceps in the right hand for the scissors, and the micro scissors I'm able to cut and bisect this lens in half. Cutting a silicone lens is rather easy with scissors, but not so easy when you're trying to grab it with smooth forceps. Switch the scissors to the smooth forceps. Carefully inching my forceps, two-handed technique, towards the tip of the haptic. Pull the haptic out. Again, I try to grab it, but it doesn't work. So I switch to the serrated IOL holders, grab the cut edge of that lens, and it pops right out. Again, using a two-handed technique, grasping, I switched hands now. I'm pulling the leading haptic away from me so I can grasp the cut edge of the optic with the IOL holders, and I pull it out. This is a 22 gauge thin-walled AC maintainer. And I use a 22 gauge thin-walled AC maintainer in that position. Why? Because it will help me push that eye towards me. So that's the idea. It's kind of acting like a fulcrum, so it prevents the eye from rotating down too much. And so that's why I put the AC maintainer that way. But as you can see, the eye is so deep set, I'm having to put some pressure on the AC maintainer to maintain its neutral position. This is a 25 gauge needle for my externalizing of the leading haptic. I have the bevel bent and facing to the right. This is the left side needle. I'm going to bend it so that it faces towards the main incision. You can see I didn't have the bevel quite right, so I went ahead and bent it another time. This is the left side needle. The bevel is going to face towards the contralateral limbal incision. This is a cartridge for the sensor lens. I placed some cohesive viscoelastic within the barrel as well as the platform, placed the lens and seat it down into the platform, pushing it down, making sure as the wings come together, the optic bends backwards, making sure the leading haptic goes straight into the barrel and the trailing haptic comes out to the back. Once I place it into the injector, make sure the trailing haptic is up and away from the barrel, and then advance the lens. You can see it's such a difficult access, and that's why it's so important to bend that 25 gauge needle, and you can bend it fairly close to the tip, especially in this case, which is such difficult access. I have the bevel of the 25 gauge needle facing to the right. The bevel of the injector is facing to the left. They're facing each other. As my assistant advances the lens, I'm docking the haptic on the bevel of the needle. She continues to advance the lens, and as she does so, I'm able to pull the needle out, and the leading haptic comes out with it. I take over, deliver the optic, and then make sure the trailing haptic comes out of the eye. Using my microforceps, just making sure that that leading haptic's not getting caught on the AC maintainer, which it is right there. And again, as you will see, access is going to be a challenge. Deep set eye, the AC maintainer is having to turn. It's actually kind of getting turned vertically because it's so deep set. Using microforceps now to hold the eye, because you can see I'm having significant conjunctival ballooning on the right side. You massage the fluid down, make sure the conjunctiva is laying on the sclera, and then with infusion off, I stab the conjunctiva and sclera at that first mark, and then I go flat. Once I go flat, I turn on infusion, get the eye nice and firm, I tunnel 2 millimeters, and then I dive down. And you have to feel. Unfortunately, with this part, it really is about feel. You need to feel the resistance of the needle going through that sclera, and that means you know you're going through 2 millimeters through that sclera. You can see here, the lens optic is not pushed away, and so I'm having a little bit of access issue here. And so I'm just trying to make sure that the lens is pushed fully away so I can place that trailing haptic into that right side needle. You see again the conjunctival ballooning, compress and squeegee out the fluid, and I did that with the cotton tip. And then once I got the conjunctiva fairly low on the sclera, I was able to execute the scleral fixation. You saw how quickly and easily I was able to grasp the haptic with microforceps, smooth forceps, dock the haptic on the bevel of the needle, and it went right in. Go ahead and internalize the leading haptic. You can see, because again of the access and the eye is turning down and towards the nose, the needle is sitting funny and it's causing the lens to turn funny as well. Again, all of this is just part of the challenges of dealing with this deep set eye, and again it's turned down and towards the nose. Using contralateral fixation, holding the contralateral incision with forceps, I stab the conjunctiva and sclera at that first mark, and then I turn on infusion. I make sure I'm nice and shallow. I tunnel through the sclera 2 millimeters, and then I dive down. Again, being able to fixate contra-incisionally allows me to hold the eye in the neutral position much more easily and more effectively. Grasp the leading haptic with smooth microforceps. dock the haptic on the bevel of the needle, and you saw there I wasn't quite aligned, but because I docked it, it stayed right on that needle. I was able to re-grab, dock it, and it slid right in. Just 2 pushes. I'm ready to go. Pulling each needle out, but not all the way. Focusing on the left side, making sure I have those smooth microforceps to grasp the haptic as it comes out. And you want to limit how much the haptic comes out of the eye, which limits how much strain there is on the optic-haptic junction. Go ahead and cauterize the tip, and then perform the same thing on the other side. Pull that right side needle away from me, and as I do that, the haptic comes out. You want to again limit how much of that haptic comes out of the eye, which will then also limit how much stress there is on the optic-haptic junction. Cauterizing the tip, and then we're ready to go. So go ahead and internalize both haptics, pushing it flush to the sclera, reapproximating the conjunctiva. And you see that the eye was a little bit soft, so the haptics were sitting a little funny. And then here you can see the optic is a little bit sitting funny because why? The capsule, the anterior capsule rim superiorly is getting caught on it. So I'm lifting the optic and getting it over that capsule. And now I have it in kind of like an optic capture configuration because of the way I placed that right side needle over the capsule. I had to make sure that the optic was over the capsule as well. Go ahead and put some intracameral Kenalog, which again, there's no vitreous in this situation. Again, very commonly in my experience, when you have these dislocated lenses, you don't really encounter a lot of vitreous. This is the surgical PI using the vitrector, low flow settings, and you're able to get a nice discrete PI, surgical PI. You don't want to place vitrector tip all the way to the angle because then you'll get ciliary body bleeding. Again, this is the suture. I always place a tenonylon suture at the end of the case. I pull the trocar out, massaging the sclerotomy. Activate infusion, and lo and behold, self-sealed. And then I take the 22 gauge thin-walled AC maintainer out, and then I'll hydrate my incision. So this is a patient who had a very deep set eye. I had access issues because it's so deep. I switched from the standard Lieberman to the narrow wire speculum, which gave me much more access to do the surgery. But again, after I did the block, the patient's eye tended to turn down and towards the nose. And that is really kind of the opposite of what you'd want when you're doing the Yamane technique, especially with my technique, since I like to make that contralateral limbal incision to externalize the leading haptic. That was really the most challenging part of this, and I had to really pay a lot of attention, making sure that leading haptic wasn't getting caught up on the AC maintainer. I use that AC maintainer again to help me keep that eye from turning all the way down. That AC maintainer was almost acting like a fulcrum, preventing the eye from turning down more. Not sure if it would have done any better if I didn't have it. I will say, in retrospect from this case, I think one thing that would have been helpful is a traction suture. The only problem with traction sutures is if I made that traction suture and I encountered bleeding, I could have had some conjunctival hemorrhage. I could have had fluid dissection. Again, it would have just replaced one other problem for another, but it would have certainly helped me with my access issues if I made that traction suture as far as in the screen, around 7 o'clock or 8 o'clock. I was able to pull the eye up and out towards me. I would have had much better access. But as you can see, this patient's eye is really fixed down and towards the nose. That's the only thing I think I could have done differently, is placing a traction suture. But as you saw, I was able to struggle through the case. Again, externalizing the leading haptic through the contralateral limbal incision, being able to turn the optic and leading haptic away from me, getting better access for the trailing haptic. You saw in this case, the cannulation of the haptics into the needle was really the easiest part. I didn't spend much time at all. They went right in without any problems whatsoever. Again, for me, the challenge here was the anatomy, the deep set, as well as having all that conjunctival chemosis. But this patient did very well with an excellent secondary IOL fixation using my modified Yamane technique. So I hope this was helpful to you, and I thank you for your attention.